Hello, welcome back to Advanced Human Gross Anatomy. Today we will be talking about the posterior abdomen. The posterior abdomen are the structures behind the peritoneal membrane. Remember, the peritoneum is what lines the whole abdominal cavity and the digestive tract organs that we've been talking about. Behind the peritoneum are organs called retroperitoneal organs, mainly the urinary system. A lot of times people doing this dissection will remove the organs that we've talked about in the digestive tract just to expose some of these retroperitoneal organs. We're not going to do that today. We're going to keep those organs in place. If you are a surgeon or working in the abdominal cavity, you won't always have the luxury of having these organs being front and center. You'll sometimes have to be able to navigate around and find the structures that you're looking for as they're in place. So it's good to have an understanding of where these structures are in relation to everything else. So when you're going to be looking at the right side of the posterior abdominal wall, you're going to have to move all of those organs over towards the left side. And if you want to look at the left side, you'll have to move the intestines and so forth over towards the right side. There will be some play in there, and you'll be able to kind of identify what you can move and how far to see the structures that we're looking for today. So what we'll do today, just an overview of what we'll be looking at here. You can see the abdominal aorta coming down. These are the structures we've seen already, the celiac trunk, superior and inferior mesenteric arteries coming down. You'll also have gonadal arteries. If we take a look at this picture, here's a better shot of what we've seen. The gonadal arteries are going to come off just below the superior mesenteric artery. They're going to go toward the testicles in the male and in the ovaries in the female. These are going to in the male, they're going to go through the inguinal canal into the scrotum to the testes. In the female, they'll just end in the pelvis at the ovaries. The gonadal veins are a little bit different here, draining the testicles and the ovaries. On the right side, they'll just go right into the vena cava, which you can see is a kind of a direct route. On the left side, because the vena cava is over on the left or on the right side of the aorta, on the left side of the gonadal veins are going to drain into the left renal vein, and before they enter into the vena cava. So on the right, they go right into the vena cava. On the left, they have to go up into the renal vein and then go into the vena cava for their supply. The kidneys, you'll see on the sides here, they're often difficult to find. They may be buried in a perirenal fat. So you have to take a blunt probe and start to search for the kidneys themselves. Be careful not to disrupt the adrenal gland, which we'll talk about in a little bit here. But the adrenal gland sits right on top of the kidney. It looks like fat, but it's got a little more rigidity, a little more consistency to it. So you should be able to identify that. But we'll try to keep that intact so that we can study that a little bit more. The renal arteries, you can see here, they're pretty substantial. They come off of the aorta near the superior mesenteric artery. They're a little longer on the right side. It's got to go underneath the vena cava and behind the renal vein. On the left side, the renal vein's a little longer, a little shorter renal artery on the left, again going behind the renal vein to the left kidney. The renal veins always sit in front of the renal arteries, draining the kidneys, going to the vena cava here. A little longer on the left, a little shorter on the right, just based on where the aorta and the vena cava is in relation to the spine. If we take a look at an autopsy picture here, this is all of the organs again have been removed. We're not going to get this clean of a shot today, so don't expect it to look quite like this. But the kidneys on the sides here, you can see the adrenal gland on the right, the kidney on the left, the adrenal gland, the aorta coming down, splitting into the common iliac arteries. Here's the vena cava, renal vein, celiac trunk, superior mesenteric, inferior mesenteric arteries. Hopefully you can see some of those things here. If you're wondering where is the kidney in relation to the body itself, this is an important thing to see and understand. Learning the anatomy is one thing. Learning where it is on a body of somebody standing in front of you is also really important. The kidney is actually about half covered up by the 12th rib here. Remember, the 11th and 12th ribs are the floating ribs. And that's right behind where the kidney would sit. So the kidney sits on some musculature that will sit right off of the kidney. From an anterior view will be in front of a muscle called the quadratus lumborum, which we'll see in a little bit, which has its origin off of the 12th rib and the lumbar vertebrae. But it's pretty much half covered up by that 12th rib. So it is vulnerable to injury. If you're a boxer, have a kidney punch back here, or get a helmet back to the backside of the rib cage here, it can be a little exposed on the lower side of the rib cage. If we take a look at the cross section here, this is a transverse section. When you look at transverse sections, I'll show a picture of a CT scan as well. You're typically looking from the feet up. So the feet would be coming toward the screen towards you. The head would be into the screen here. So you can see the right kidney here, the left kidney here, and they're embedded. They're kind of embedded in this renal adipose capsule, this perirenal fat. This is what you had to dig through to get to find the kidney, to identify it coming from the abdominal cavity. It has a renal fascia that surrounds that perirenal fat. There's a renal fascia, connective tissue, that surrounds this. This will take some investigating to identify the branches that are going to and from the kidneys, but hopefully we'll be able to dig through and find some of these structures. Here's that CT scan. So from the feet up here, you're looking, here's the right kidney, here's the left kidney, here's the liver sitting back here. So you can take a look there. Now, the hilus of the kidney is where things are entering and exiting. Entering being the nerve supply, the renal arteries, exiting being the renal veins, and the ureter. The ureter comes from the kidney. It goes over, comes down, lays over the top of this muscle called the psoas major, and then travels over the common iliac artery before it enters into the bladder on either side here. So you can see, again, over that psoas major, over the common iliac artery and vein before it enters into the bladder. Okay. The quadratus lumborum muscle is on the outside here. You can see on each side. We'll have a better picture of this later on, but it lays lateral to the psoas muscle. It comes off of the 12th rib and the transverse processes of all 5 lumbar vertebrae, and then comes down and attaches to the crest of the pelvis. But that's what the kidney will kind of sit on top of that quadratus lumborum muscle. The iliopsoas muscle here you can see the crest of the pelvis on the right side where the quadratus lumborum is coming down. This is going to have a muscle here called the iliacus, which joins with the psoas and becomes the iliopsoas on each side. It's kind of on the anterior side of the ilium. In the bowl of the pelvis, kind of underneath the abdominal viscera. The psoas minor is also a muscle coming off of the lumbar spine. It's not part of the iliopsoas. We'll take a look at some of these muscles in a little bit as well. During this dissection, what I would like you to do is free up at least one kidney, keep it attached by the vasculature, but free it up a bit so you can open it up. So we're going to take we're not going to remove the kidney, we're just going to kind of loosen it up. And I want you to take your scalpel and cut it in a coronal section on the back side here, from an anterior to posterior. So you're going to have an anterior part and a posterior part. And you're going to almost be able to open it up like a book, kind of opening it up. And so what you'll see is the coronal section. We'll take a look at an artist's drawing of a coronal section of a kidney here. You can see it starts with a fibrous capsule. So what we've done here is taken this right kidney in this case, and this picture is showing kind of that we've removed the anterior portion. You're just going to have it opened up a little bit at the hilus being the hinge. But here you can see this renal capsule that kind of encases the kidney itself. This is a fibrous capsule on the outside. Then there's a renal cortex, which is this outer portion right here, this cortex. Generally speaking, the cortex is where you'll find where the filtration is happening. This isn't a course in histology, but this is where the nephron would sit. I always think of that actor from High School Musical, Zac Efron. That might help you remember that the nephron sits in the cortex. The medulla is going to sit inside of that then. The medulla is this inner portion. It contains the renal pyramids. You can see these triangular shaped structures here. When you open up the kidney in that coronal view, you'll actually see the 3D structure here. They call these the pyramids. You think, oh, they're just kind of triangular shaped. Why don't they call them triangles? Because they actually do get wider at the base, both in width and depth. So you'll be able to see how they do look more like a pyramid shape. And it's in the medulla that you're actually getting that excretion and reabsorbing at the tubules. So the collecting tubules come down. You're going to, eventually the urine is going to be filtered through that nephron, produced in the nephron. And the collecting ducts come down through these pyramids. Through the tips of the pyramids here, they call these the papilla of the pyramids, these tips. And then urine will collect down into these minor calyces here, going into the major calyces here, coming down into the renal pelvis, which is this the portion of the kidney where the urine is going to collect. And then eventually out of the renal pelvis, it's going to go into the ureter, which we saw exit down into the bladder, coming down that way. Here is just an actual cadaveric kidney next to the artist's rendering. Here you can see where we get some of where the artist got his or her inspiration to draw this the way that they have, where the pyramids being here, the cortex being on the outside, the medulla inside, the cortex, where in the pyramids, the collecting ducts come down, flow ultimately into those renal papillae, down into the minor calyces, major calyces, into the pelvis, out the pelvis, into the ureter, into the bladder eventually. Let's see here. Let's take a better look now at the adrenal gland. Now this is, you can see the kidney. Netter here has drawn his hand actually. Hopefully you're going to wear gloves as you do this, but pulling back some of he's holding the kidney here and then pulling back with the forceps some of the other structures. And you'll see in that renal fat is this adrenal gland or suprarenal gland. So it sits on top of the kidney. And again, you have to dig through it. You have to kind of find it. But even in the drawing here, you can see how it's a little bit different consistency than the perirenal fat that's around it. Let's see. So it's going to be a little challenging to clear away that fat, but leaving the adrenal gland. It's also called the suprarenal gland, the adrenal gland. So when we look at the blood supply to it, here's a different view of the blood supply. So you can see got the kidney and the adrenal gland up on top. It's important for blood to get to this gland so that it can have its nutrition for its important functions. The outer portion of the adrenal gland is the cortex. It has another cortex and medulla of the adrenal gland itself. Within the cortex is where you make steroids, mineral corticoids, glucocorticoids. Some sex hormones are produced in the adrenal cortex. And then in the medulla is kind of like a sympathetic ganglion, except that it's endocrine. The medulla does not have postganglionic nerves going from it. It has preganglionics going to it, but not postganglionic nerves coming from the medulla. But rather, secretory cells within the medulla called chromaffin cells. These actually make and release adrenaline to be released into the blood supply. So this allows for a whole body stimulation of the sympathetic nervous system from that inside medulla. But it's important that you get the blood supply going to the adrenal gland here. That's going to go to the cortex and kind of percolate its way through the cortex on its way into the medulla here. Some of the blood supply that you're going to see, so we'll see it here, the inferior suprarenal or the inferior adrenal artery. You can see coming right off of the aorta, going to the bottom portion of the adrenal gland. There's a, I'm sorry, here, that's this one here, coming right off of the, directly off of the renal arteries. I'm sorry, I was showing the middle suprarenal artery. The inferior renal artery or suprarenal artery coming off of the renal artery, going to the bottom portion of the adrenal gland here. Here you can see the middle suprarenal artery coming directly off of the aorta, right by the celiac trunk, coming over to the adrenal gland. And then the superior portion gets actually supplied off of the aorta, just under the diaphragm, is this superior, I'm sorry, the inferior phrenic artery coming off of here, going to the diaphragm. But off of that inferior phrenic artery are branches going to the superior portion of the suprarenal gland, called the superior suprarenal arteries or superior adrenal arteries, coming off of the inferior phrenic artery. The venous return, you can see here the middle suprarenal vein, the superior suprarenal vein. Here's the inferior suprarenal vein coming down. Same names, inferior, middle, and suprarenal, superior suprarenal veins flow right into the vena cava, which has been cut here so we can see the right side of the adrenal gland. Now, as a review of the abdominal aorta, some things to pay attention to again are the celiac trunk we've seen in a previous dissection. You've got the renal arteries going to the kidneys, the superior mesenteric artery. Here you can see the gonadal arteries coming down, inferior mesenteric artery. We've seen these before. And then it comes down into the bifurcation of the aorta, splits and becomes the common iliac arteries. Off of the back of the abdominal aorta, you're going to have lumbar branches that supply the posterior body wall of the abdominal cavity. Similar to the thoracic, in the thoracic cavity we had thoracic arteries branching off of the thoracic aorta going into the thorax. These joined in and became the intercostal arteries and that costal groove of the ribs. So, but these are going to come off of the lumbar on the back side, so you might be able to find some of those here too. Now, eventually in this dissection, you may be interested in seeing what does the aorta look like inside. So you can, I would encourage you to pick a place that won't disrupt the other dissections too much of what we're looking at, and cut the aorta. Just take a transverse section straight through the aorta, either in the thoracic cavity above the diaphragm or in the lumbar cavity, or in the abdominal cavity, in the descending aorta, and take a section, just cut right through it. And you'll need to take out some of that dried blood. It will look kind of like dried red clay. Take a blunt probe, clean that out a little bit, and look for the plaque buildup. It's interesting sometimes to look at the plaque buildup on the aorta. It's actually kind of shocking in some cases. Some will have significant buildup. And as you look at this buildup, you might think to yourself, "Oh my, I'm done with French fries. I'm not going to eat any more fried food." And that's probably good. That's a good thought. It might last a day or two until you go out to eat with your friends. And boy, the French fries just look so good, you're going to want to have some more. But you'll be able to see that just to remind you of where some of those fatty deposits get built up. So that might be kind of shocking to some of you. So reviewing the inferior vena cava, Let's look down into this shot here. Well, I'll go back here. Remember, the inferior vena cava sits to the right side of the aorta. Remember, the right gonadal artery, or right gonadal vein, rather, is going to go right into the inferior vena cava, where the left gonadal vein is going to drain into the left renal vein before it goes into the vena cava. And then let's not forget about the portal system, the hepatic portal system, draining the anterior abdominal digestive organs. Remember, we've talked about this before with those intestinal branches from the small intestine that have all been cut off here. The superior mesenteric vein draining the small intestine and the proximal part of the large intestine. The inferior mesenteric vein draining the distal part of the large intestine. That joins up with the splenic vein, which joins in with the superior mesenteric vein, which has then branches from the gastric veins coming in, all forming into that big portal vein in that hepatoduodenal ligament that we saw before. Remember that all of the nutrition within your abdominal cavity, when you take things in, it goes into the small intestines for absorbing. And that all needs to get filled, all of that nutrition, all of those materials, hopefully good nutrition, but it could be bad nutrition too. It could be chemicals, drugs, and alcohol, things that you've taken into your system. They first get filtered through the liver, through this portal vein, so it all kind of funnels into that portal vein before it goes into the liver, which will eventually, get filtered, that we've talked about in the previous dissection, going out the hepatic veins, then leaving the liver, going into the vena cava, and then into the heart. So once it's been filtered, it can be circulated through the body. So the portal system is an important one to see. The caval system is also another system draining blood from the body wall. So it drains the posterior abdominal wall to the posterior to the vena cava. When you have cirrhosis of the liver, disease process of the liver, we talked a little bit about that previously too, with those portal triads where they start to have necrosis and some scar tissue build up, this disease state. You can sometimes you'll see this on the cadavers too. The liver will look. It'll look a bit bumpy. It looks diseased. You can see it from the outside. As you compare it to maybe there's another body in the lab that will have a healthier liver. Compare the livers to each other and kind of see what you see. The scar tissue, though, that forms at those portal triads, remember that's where the filtering is happening. That will kind of back up that filtration system, makes the blood pressure in the portal system go up. So if you're not having good filtration through the liver, it will start to back up through that portal system. And so what you'll find some varicosities, some of these issues where there'll be some drainage issues that you'll be able to notice. This can be diagnosed by your doctor, both in the caval and the portal systems where they communicate. So these varicosities can happen in a couple different areas. One, down here at the near the rectum and the anal canal, at the anus, you might see some varicosities. We call these hemorrhoids. So that can be an indication that there's some backup of the portal system, some pressure built up in that portal system. You can also see it, you might have it at the esophagus as it's coming down from the esophagus. You might have some varicosities that maybe break open in the esophagus. And this could be, typically these can be stopped, that bleeding can be stopped, but sometimes that can be fatal as well if it gets too bad or goes too long. And what you'll notice here is you'll start vomiting red blood, deep red blood here. If it's red, you know that it came from the esophagus, or the very, very proximal part of the stomach. If you're bleeding from there, blood that's coming from the distal part of the stomach or into the small intestines will be more of a coffee colored. As the blood interacts and mixes with the digestive enzymes, it changes its color. But if you're puking red blood, that's an issue. That's bleeding within the esophagus, which can be very serious. And also another indication varicosities are just buildup of blood pressure within that portal system. The umbilicus is the third part here, kind of right at the umbilicus area. Excuse me, are where that sections where that portal and caval system kind of draining the abdominal cavity for the portal system, and the abdominal wall with the caval system where they communicate at the umbilicus. You can see these like snake-like veins, the veins that kind of look like snakes just right underneath the skin near the umbilicus, which somebody named that caput Medusa, which is the head of Medusa. If you remember in your Greek mythology, Medusa was the goddess with the snake hair, so that can kind of look like that. But those three, if you're finding clinically those three areas where there's varicosities, that can be due to scar tissue buildup, not allowing proper filtration through the liver, and then building up that blood pressure as it comes back into that portal system. Let's review now some of the posterior abdominal wall musculature. Now here the organs have been removed. Ours will not look this neat as Netter has drawn it. But here you can see the psoas major muscle. Let's just take a look here. It's coming from the transverse processes of all 5 lumbar vertebrae, L1 through 5. Coming down, it joins with the iliacus. We saw this a little earlier. This iliacus comes from the crest of the pelvis on the inside of the bowl of the pelvis. Where the iliacus and the psoas major join, we change its name now to the iliopsoas muscle. This comes down and attaches actually to the lesser trochanter. It comes over the neck of the femur, over the pubic ramus here, comes over and attaches down onto the lesser trochanter of the femur. Remember, when you're talking about muscles, they have an origin more proximally and an insertion more distally. When a muscle contracts, it typically will bring its insertion towards the origin. So in this case, that psoas and iliacus are going to be hip flexors, and external rotators are going to kind of bring that hip up and out. The psoas minor, you can see here, coming from the lumbar spine again. This does not have a common attachment. It's not part of the iliopsoas muscle. It comes down and attaches more to the inside, the top of the attaches to kind of the anterior side, the inside of the pelvic brim here, and that just more helps you to sit up. It's bringing the pelvis, allowing the spine to kind of hinge up from the pelvis. So this allows you more just to sit up. If you're sitting up in bed, this will actually be a massive hip flexor, the psoas major and iliacus. But the psoas minor doesn't cross the hip joint, just the spine. Quadratus lumborum, we saw that just lateral now from the psoas major, lateral to this. So you can see how it comes kind of down and out from the 12th rib and the lumbar spine, coming down to the crest of the pelvis. This will help you flex at the waist as well. Also helps with some lateral movement of the lumbar spine, some side bending. Let's go lateral to that yet. Now you've got this muscle here. Remember the abdominal cavity, the transversus abdominis. This actually has fascia attachments into the spinal column, the posterior abdominal wall, as it comes around towards the front. So then here you can see the abdominal wall has been cut. This middle section would be that internal obliques. Here's the external obliques. Remember, these attach more on the front side at that aponeurosis, which will make that rectus sheath as that comes down. You should be able to kind of see that as well. So let's review now some of the nerves that are coming into here. There's a lumbar plexus, which goes over these muscles that we just talked about. So if we just superimpose now the nerves on top of that other picture, we'll see the plexus. Now, in the thoracic area, there was no plexus. There was no collection of nerves. They were very neat, very organized. They come out of the vertebral column from the roots that went kind of right around. Followed that intercostal, that costal groove around the posterior abdominal wall. In the lumbar spine, we're actually going to form these plexuses. They're going to have nerves that come down. We'll identify these now. Nerves that come down and supply areas both in the abdominal cavity and then also into the lower extremity. So the first one I want you to pay attention to here, this is called the subcostal nerve that comes off of T12. This is actually the 12th, the intercostal nerve number 12 coming down here, subcostal. The next one down, it actually is two coming from L1, both of these, but there's the iliohypogastric and the ilioinguinal. Now, on a cadaver, these are often fused. They look like one sometimes. They're coming right over that quadratus lumborum muscle. But these are the iliohypogastric. If we follow this around, it's going to come around the abdominal cavity, kind of turns and comes across the front of the abdomen through here. The ilioinguinal, by its name, is going to come down and then pierce through, it's going to go through that inguinal canal and then down into, in the male, it's going to kind of supply sensation at the top of the scrotum. The female, it's going to give sensation at the top of the labia majora, the ilioinguinal. So iliohypogastric, ilioinguinal coming right here. Off of L1 and 2 is the genitofemoral nerve. This one kind of sits right on top of the psoas major muscle. Genitofemoral, what is that going to do? It's going to split into two branches. You can see here right off of that psoas major. The first branch, the femoral branch, is going to come down and supply some of the sensation at the anterior thigh. The anterior part of the thigh on the front side here. And then the genital portion is going to go down and continue with the ilioinguinal, is going to continue down into the inguinal canal and divide kind of into, down the inguinal canal and then into the scrotum for the male, into the labia majora, kind of the front of the labia majora for the female for sensation. But in the male, this genital portion of the genitofemoral nerve will come down and it will actually give motor innervation to the cremaster muscle. Remember the cremaster muscle, that muscle that is in that inguinal canal. In a male, there's a clinical test, light stroking, just light sensation to the femoral triangle, which is the space between that inguinal canal, the sartorius muscle here, and the adductors, this region right here, will actually create a mechanical activation of that cremaster muscle, elevating the testes toward the abdominal wall. So it'll engage that cremaster muscle. Women don't have a cremaster muscle, so this won't work in a female, but in a male, this is a test for the integrity of that genitofemoral nerve. If we keep going down, so now we're to here, this lateral femoral cutaneous nerve. This one runs right over the iliacus muscle. It's going to innervate the lateral part of the thigh. Coming down here, you can kind of see it piercing down through the fascia down onto the lateral part of the thigh. If you're a country line dancer, and this is the one where you would slap, hey, you would slap your thigh as you're doing that dance coming down this way. This is what you're giving sensation to that lateral portion of the thigh. The femoral nerve, this is a big nerve. It's actually pretty substantial. It sits behind the psoas major muscle. You'll be able to see this. This comes from lateral femoral cutaneous, coming from L2, 3. And then femoral nerve coming from L2, 3, and 4, coming behind the psoas major muscle. This is going to go under the inguinal ligament and travel into the thigh. This is actually going to be motor innervation to the quadriceps. It will also be sensory information to the anterior portion of the thigh and the medial leg, so below the knee on the medial side. L234 also gives us the obturator nerve. The obturator nerve comes down here and goes through, pierces through the obturator foramen, which sits kind of between the pubic ramus and the ischial tuberosity, this big, kind of a hole within the pelvis covered by a membrane. It's a big hole, but not much goes through there, just an obturator artery, nerve, and vein. But the obturator nerve is going to come down through that and innervate the adductors, the adductors of the thigh, bringing the leg towards midline. It will also give sensation to those areas as well. Here you can see some of the lumbosacral trunk as it joins with some of the branches from the sacral plexus here as well, the lumbosacral trunk, mixing the lumbar and the sacral plexus nerves. And you can still see, even on this picture, you can see some of that sympathetic trunk. Remember that the sympathetic trunk only really comes from the thoracic and the first two lumbar vertebrae, but it has a chain of ganglia that go way up to the base of the skull, way down to the sacrum, you can see down through here. These, again, are post-ganglionic fibers leaving towards their effector organs. The gray rami, you can see, the aorta has been cut here, but the gray rami from the sympathetic trunk also are going to the aortic plexus, kind of in front of the aorta here. Okay, some of the nerves that you'll be able to see. Now, if we look at the diaphragm, now just a review of the diaphragm, this is from underneath. This is an inferior view from the abdominal cavity looking up toward the thoracic cavity. You'll see that it's kind of held in place by, there's a sternal portion where it attaches to the sternum and the xiphoid process here. There's also going to be costal portions which attach it to the rib cage on the sides. These attachments create a dome separating the thoracic from the abdominal cavity. They hold it in place. They anchor it to the sides. You'll see the openings here. There's an esophageal opening right here. There's an aortic opening here, which you can see, and then there's an opening for the inferior vena cava. This is just going to pierce right through into the right atrium of the heart, and you can see those openings there. There's also arcuate ligaments. You can see the psoas major and quadratus lumborum have been removed on the left side, but here they are on the right. There's these arcuate ligaments that will that kind of hold it to those muscles there. Thus, the diaphragm has a firm attachment all the way around. The medial arcuate ligament would be covering the psoas major. The lateral arcuate ligament would be covering the quadratus lumborum. You can see here medial towards midline. Let's see. And herniations. Let's just talk briefly about some herniations. These can happen in a few places, really any place where you're getting, where bowel could kind of come through these openings. Sometimes you'll see them at the sternum here, at the xiphoid. You see kind of a bulge underneath the anterior abdomen, right underneath the xiphoid, as bowel starts to come up and pierce through the diaphragm there. Most often, though, you'll see it at the esophagus. You'll see it at the esophageal opening here. They call these a hiatal hernia. So this is going to be where bowel will kind of, stomach and intestinal material will come up through, entering into the thoracic cavity through this way, the hiatal hernia. You can see how the musculature of the diaphragm is really on the outside. It's laterally positioned here. There's a tendon that makes up this central portion. The central tendon is what the heart sits on, and the musculature being this outer portion here. The nerve supply, we've spoken about this already, but the phrenic nerve innervates the diaphragm, coming from C3, 4, and 5, keeps you alive. C3, 4, 5 is the phrenic nerve. And that gives it the diaphragm its motor innervation, but the sensory innervation is really from branches off of intercostal nerves supply the sensation. So when your diaphragm is working hard and lactic acid can build up, you're going to get what you'll kind of describe it as a side ache. And so those sensory innervations are going to be around the sides this way. And that's your body's way of saying, if you're on a long run, that's your body's way of saying, it's time to stop. Let's let this lactic acid disperse out of that musculature, get more nutrition back into your body, which might be a good idea to slow down. Now that is what I wanted to talk about from the the posterior abdominal lecture. Let's just introduce a little bit of the pelvis here. We're going to be talking about this in the future dissection, so let's just get a little introduction to this. The pelvis is made here up of the sacrum, which is the bottom of it sits at the bottom of the lumbar spine, and these two coxal bones here. My favorite name for these is the innominate bones, which I think is funny because innominate literally means without name. It's innominate, it's without name, but they named it that, which I just think is funny. So the coxal bones, the innominate bones, come to the sides here. They're actually made up of the ilium, which is the big fan-shaped portion here. So Simon says, put your hands on your hips. Don't actually do that. That's a joint. It's quite deep. It would be very painful to put your hands on your hips. What you're doing is you're putting your hand on your ilium, the top of the iliac crest here. It's made up of the pubic bones, which are kind of this ramus that sits here, the pubis, and then the ischium is what you sit on underneath here. The pelvic brim, there's a false pelvis. The pelvis kind of looks like a big funnel if you consider it falling down. The false pelvis is this top portion here where the abdominal contents would be. The true pelvis is this, you can see the this ischial spine here, kind of sitting around it, at the bottom of the ilium, where the pelvic cavity would be. So the true pelvis is the bottom portion where the pelvic viscera are located. Now, holding kind of the bottom of holding the pelvic viscera in place is this sling, this hammock of musculature that we call the pelvic diaphragm. So let's take a look at the pelvic diaphragm. We'll see this later on in more detail when we do the dissection. We'll learn some of these specific muscles. I've chosen the female pelvis to show you here because it's pretty much the same as the male, except you just have to get rid of the vagina in the male pelvis. So from a cross section, this is anterior. Here's the pubic symphysis. Well, I don't know if that's the symphysis, but here's the pubic bone. If it's cut mid-sagittally, it'd be near the pubic symphysis. Here's the sacrum. You can see how this bowl of the pelvis kind of sits like this. This is looking straight top to down inside the bowl of the pelvis. Here's the pubic symphysis that you can see, and the sacrum is on the bottom side here. This hammock, this sling of musculature that sits there. Now, central in this is going to be these the openings on the female, the urethra, the vaginal opening, and the rectum, the rectum here. So 1, 2, 3. In the male, same thing, just without the vagina in the middle. This is where you'll find. We'll look at these muscles again in a later dissection. The perineum. Now, let's go to this one first. Let's look at the male perineum first. If you're a nursing assistant, or if you're working in a setting where you may be assigned peri-care, this is care of the perineum, this area between the legs. So it's an area. It's a diamond-shaped area. You can see the male here. Its boundaries are the pubic symphysis on the top, the coccyx on the bottom, and then on the sides, the ischial tuberosities on each side. It's the same triangle for the male and the female, but in the male, you can see here that if you split the ischial tuberosities, kind of make a line here, you'll have a front and a back. These two triangles make up the perineum. So there's a urogenital triangle on the top, and a anal triangle on the back. The urogenital triangle is going to contain, it's where the urethra and the male is going to come through that through the urogenital diaphragm, and it's going to go in the male. It's going to course anteriorly as it goes out the penis. And in the female, this we'll see in a bit here, but in the female, the urethra, and it will also contain the vagina. On the posterior aspect of the perineum, the anal triangle contains the exit of the anus here. If you see the female, this triangle's not drawn here, but if you imagine the pubic symphysis, the ischial tuberosity, the coccyx, ischial tuberosity, and pubic symphysis, cut that in half. You can see between the ischial tuberosities, you're also going to have the exit of the urethra and the vaginal opening here. On the urogenital diaphragm, or triangle of the perineum. On the anal triangle of the perineum, you'll see the exit of the anus on the back side there. So I hope that this was helpful. Hopefully you learned something today about the posterior abdomen. And I look forward to seeing you in lab. Thanks for your time. Have a great day.